Hello student, topic of our lecture, apical periodontitis of primary teeth, features of diagnosis, clinical cause and treatment, prognosis and outcomes. Apical periodontitis is an inflammatory process which affects the periodontal ligament and spread to the adjacent bone structure. Etiology of apical periodontitis. The most periodontitis have an infectious origin. Microorganisms and their metabolic products penetrate to the periodontal ligament from the inflamed or necrotic pulp and cause alteration of ligament in periapical area. You see that it can be such microorganisms as bacteroids, Fusobacterium, Actinobacillus, Porphyromonas gingivalis, Streptococcus micros, Treponema denticola, and so on. At the same time, biogenic amines produced in inflammation and in the process of pulp necrosis increase the inflammatory response and cause allergic response. Second group of etiological factors causing the development of apical periodontitis in children, chemicals and toxic factors. Some irritant or aggressive chemicals or drugs used in the treatment of pulpitis and dental caries may infiltrate periodontal ligament and provoke inflammation there. And last group include traumatic factors, such as iatrogenic factors, for example, over-instrumentation of primary tooth root canal, or maybe inadequate irrigation, or maybe extrusion of filling material used for sealing of root canal system. In this case, traumatic factors may provoke periapical inflammation. And traumatic factors also include household acute trauma. For example, if a child is being hit or maybe dropped, or result of chronic dental trauma in case of using of some orthodontic appliance, maybe because patient has some bad habits. To all these factors, traumatic factors, may result in traumatically exposed pulp because they cause violation of microcirculation in the pulp. Classification of apical periodontitis. Nowadays, most common classification used in our practical work, international classification of disease, number 10, proposed last version in 2019 year. Apical periodontitis include in the group of the disease of pulp at periapical tissue, and according classification, we may put diagnosis such as acute apical periodontitis of pulp origin, chronic apical periodontitis divided into apical or periapical granuloma and apical periodontitis, periapical abscess with sinus, it can be dental or dental alveolar, and periapical abscess without sinus, dental or dental alveolar, and of course radicular cyst. Diagnosis of periapical inflammation is made as an interpretation of combination of clinical symptoms and radiological science, and also morphological change. So nowadays, in our practical works, very often we use clinical classification. One clinical classification you can see, one of them you can see on this slide. According to clinical classification proposed by dentist Lukomsky, apical periodontitis in children can be acute and chronic. Acute form of apical periodontitis divided in your acute serous apical periodontitis and acute suppurative apical periodontitis or purulent apical periodontitis. Chronic form divided on chronic fibrous periodontitis, chronic apical granulating periodontitis, and chronic apical granulomatous periodontitis. Also, this subgroup include exacerbation of chronic apical periodontitis and radicular cyst. Clinical features of acute and exacerbated chronic periodontitis in primary teeth. In pediatric dentistry, in primary teeth, acute apical periodontitis is extremely rare. And it happens, as a rule, in healthy children with a high level of immunity as a result of etiological factors of considerable strength. Very strong etiological factors. For example, microorganisms with high virulence or resistance, or maybe in case of using of very strong irritant or drugs for treatment and sealing the root canal in primary tooth, or as a result of mechanical trauma. Acute apical periodontitis, symptoms of acute periodontitis, you may see in clinical case of acute or exacerbated chronic pulpitis. Why? Due to the white apex of the root at the stage of root formation or resorption. And because very close interaction is present between pulp and between periapical ligament, and inflammation spread into the periapical inflammation, and clinically we see signs of apical periodontitis. Often the pulp remains vital due the reason of this rich blood supply to the pulp, high elasticity of neurovascular bundle, and large regenerative capability of the tissue. And often clinical signs of acute periapical inflammation occurs during treatment of pulpitis or 2 weeks after the pulp therapy has been completed as a result of irritation of periapical area during the treatment of pulpitis. But these symptoms rapidly disappear. Manifestation of disease, I mean apical periodontitis, is in children is more expressed in comparison with adults. General condition is characterized by such typical manifestation of symptom of intoxication as a fever, violation of sleep, appetite, or headache. That occurs due to the rapid penetration of toxins from the periapical tissue into the bloodstream and development of non-specific immune reaction. The rapid penetration to the bloodstream, it happens due to the good permeability of the vascular wall and high degree of the vascularization of the tissue surrounding the teeth in the children. Vascularization of maxillofacial area in the children. Exudative phase of acute apical inflammation is developing very fast. Cirrhosis stage tends to the purulent for a few hours. Because periodontal ligament in primary teeth is represented by more friable than that in adults the connective tissue that contain more cellular elements and blood vessels, but less fibrous element. The local inflammatory process quickly tend to diffuse and involves in process periapical tissue such as bone, periosteum, mucous membrane near the causal tooth, soft tissue, and regional lymph nodes. Again, which is due to their structural features in childhood, and of course, as you remember, relatively wide periodontal space, close connection with the tooth pulp because wide apex, and more high level of reactivity to various factors exposure. In children, exacerbation of chronic apical periodontitis occurs more often than acute apical periodontitis. Causes of exacerbation decrease in non-specific immunity. For example, overcooling, transferred acute infection, exacerbation of chronic internal diseases, and so on. The clinical picture of exacerbation of chronic apical periodontitis is the same as an acute periodontitis. Clinical manifestation of acute or exacerbated chronic periodontitis depend on ways of exudate spreading. For example, if exudate spreads in bone through the wide medullary spaces in the bone, this is also features of the structure of the bone in childhood, it may lead to the development of osteomyelitis, abscess of the bone, or even if it spread to the bloodstream, development of the sepsis. Or if exudate from periapical area spread under the periosteum, it may lead to the forming of subperiosteal abscess or so-called periostitis. But if it spread through the root canal or periodontal ligament, it result in development of alveolar abscess. As you remember, I told that chronic periodontitis in primary teeth is more common if you compare this with acute process in children. Periodontitis, chronic apical periodontitis, develops as an initially chronic inflammatory process. Initially, chronic inflammatory process develops due to prolonged irritation to the periodontium by weak damaging factors. For example, small dosage of microorganisms, biogen amines, the products of metabolism, and so on. Clinically, initially chronic inflammation develops almost without any symptom. Why? Because small dosage of exudate, inflamed exudate, flow out from the porous, not compact structure of the dental hard tissue and wide apex of root canal. And this exudate is not collected near the apex. Chronic apical periodontitis can be detected in teeth, primary teeth, with a shallow cavity and closed pulp chamber. And I repeat, the tooth usually remains asymptomatic, and child or parents are unsuspecting of presenting infection. There are three morphological types of chronic periapical inflammation: fibrous, granulating, and granulomatous. Most common type of morphologically of periapical inflammation is granulating. It's so-called productive type of chronic inflammation. As I told, this type dominates, and clinically you may see formation of the fistula on the jam or skin of the face. On the X-ray, granulating periodontitis characterized as a large amount of bone extraction and described as an irregular shaped periapical radiolucency with a poor defined margin. Clinically, granulating tissue can be detected inside the root canal. Why? Because granulating tissue from the periapical area through the white apex ingrow into the canals in the teeth, especially in primary teeth with not completely formed or resorbed root. One small feature of granulating periodontitis in primary teeth that the focus of inflammation is often localized in the area of the root furcation, but not near the apex. Why? Because anatomical structure of the primary teeth. It is known that in the bottom of the pulp chamber there are about 1-3 additional canals passing through the dentine in direction from the pulp chamber to the root furcation. So microorganisms, the products of their metabolism, or maybe biogen amines as a result of inflammation and necrosis in the pulp, penetrate through these canals into the furcation and cause inflammatory response. Next type of chronic apical periodontitis is a fibrous apical periodontitis. This type is more rare and usually develops in teeth with completely formed root, but never observed in immature teeth or on the stage of root resorption. This form of periodontitis is the most favorable outcome of periapical inflammation, and on the radiograph is characterized as a widened periodontal ligament space with preservation without destruction of lamina dura. Please remember that apical periodontitis of primary teeth have different effect on the future of the root of primary tooth or development of the permanent tooth. What does it mean? It was found that inflammation which present in the periapical area of primary tooth may cause premature to early pathological resorption or delayed or even stopped resorption, depending on nature of the inflammatory process. Premature pathological resorption can be result of granulating periodontitis, or maybe you may see in primary teeth with pulp treatment, in tumors, or in follicle cyst. And delayed pathological resorption more often is determined when canals were sealed by hardening material, canals of primary teeth, I mean, in the absence of gem of permanent tooth in radicular cyst, or in the case of displacement of gem of permanent tooth. For us, also very important influence of the apical periodontitis of primary tooth on the further development of the permanent tooth. Effect depend on the stage of gem of permanent tooth. Inflammation presenting in the periapical area of primary tooth may spread to the gem of permanent and involve in this inflammatory process. And if follicle gem of permanent tooth is in the stage of cell differentiation of the tooth gem before mineralization, such inflammation may lead to the death of the follicle. For example, you may see on this X-ray that chronic granulating periodontitis of tooth 585 spread on the gem of permanent tooth that lead to its death. You cannot see gem of permanent tooth on this X-ray. If gem of permanent tooth is on the stage of its mineralization, in this case, involvement in the inflammation may lead to the development the local hyperplasia, to the disorder of the enamel and dentin structure. For example, here you may see periodontitis of primary incisors, periapical abscess with sinus, inflammation spread to the gem situated in the bone near the root of primary tooth, and it was result to the disorders of enamel and dentin formation in permanent tooth. The diagnosis of such problem, the name of diagnosis is a local hyperplasia. More effect of periodontitis of primary tooth on the gem of permanent tooth can be premature eruption of permanent tooth as a result of destruction of lamina dura of gem of permanent tooth. If purulent exudate, granulation tissue or cyst press on the gem of permanent tooth, it may lead to the displacement, the position of gem of permanent tooth. For example, you may see this situation here, and infection penetrating into the pericoronal space or follicle of a permanent tooth may lead to the death and development of follicular cyst, like here. And please remember that periodontitis apical periodontitis of primary tooth is considered as a focus of chronic infection for organism of the child, because it's proved that chronic periapical infection releasing microorganisms, their toxin or antigenic particles into the blood and lymph stream is a source of chronic intoxication and sensibilization. Diagnosis of periapical inflammation. Diagnosis of periapical inflammation is based on the analysis of complaints, anamnesis of disease, clinical examination, the data of clinical examination, somatic anamnesis, the data of temperature test and electric pulp test, and radiological signs. First of all, we should analyze history of toothache. In acute inflammation, periapical inflammation, classic symptom is a dull toothache, usually well localized to restored or diseased tooth. But in children, it may be difficult to determine whether an upper or lower tooth is affected. But please remember that the affected tooth is painful to touch. That's why we use such additional method as a percussion. We use vertical percussion, and the tooth should be non-responsible to the sensitivity test I mean temperature test, but some response can still be caused by percussion tenderness. In chronic periapical inflammation, ZUB can be asymptomatic. Clinical examination include analysis of the color of the tooth crown, usually gray or grayish, result of percussion, sensitivity to the percussion, vertical percussion, demonstration of excessive tooth mobility not associated with physiological exfoliation, and gingival mucosa condition can be estimated because you may see fistula, sinus, or gingival swelling, not because marginal periodontal diseases, but as a result of complicated caries. The temperature test and electric pulp test in pediatric dentistry are difficult to perform because of the child behavior. The X-rays examination should be used for diagnosis of periapical inflammation, and the aims task of the intraoral periapical radiograph are the following. Assessment of the status of the tooth root, for example, stage of root formation, degree of resorption, kind of resorption, pathological, physiological, presence of internal, external root resorption. Assessment of the state of permanent tooth gem, we mean what? Lamina dura of permanent gem. For example, here you see violation of integrity of lamina dura of permanent gem of permanent tooth. Of course, we may detect localization of pathological process, periapical area, maybe bifurcation, size of this area. And of course, we need in radiograph for estimation of the working length of the root canal. Treatment of apical periodontitis of primary teeth. There are two approaches in the management of non-vital and abscess primary teeth with necrotic pulp. Surgical or tooth extraction and conservative, so-called non-vital pulp therapy technique or complete pulpectomy. When we put diagnosis apical periodontitis in primary tooth, the first question what should we answer, what is the better, extraction or restoration of primary tooth? And this decision should be taken into account the following factors. First of all, the interest of child, because each child is an individual and treatment should be planned to provide the best that is possible for that individual. Unfortunately, very often we choose the method management of apical periodontitis according to interest of dentist or interest of the parents. Second one, what should we take into consideration? Of course, the tooth. Primary tooths are often considered by parents and even some dentists as being disposable, because there comes a time when they will be exfoliated naturally, physiologically. However, loss of the tooth before its time has a considerable significance in the child life, because loss a tooth earlier gives a message to the child that teeth are not so valuable. It can be then difficult to motivate a child to care for their teeth. but well-restored primary dentition can be source of pride to young children and encouragement for them to look after their following permanent teeth. So, disadvantages, summary, what are the disadvantages of early extraction of primary teeth with apical periodontitis? Loss of space, because it leads to the malocclusion. Reduced masticatory function, especially if posterior teeth are extracted. Of course, some problem with speech, with pronunciation, in case of extraction of anterior teeth. Of course, psychological disturbance, early absence of anterior teeth. And please remember that any surgical procedure require using of anesthesia. That's why we should remember about that extraction is the anesthetic and surgical traumas. So what is the better? We come back, extraction or restoration. There are some indication for extraction of primary teeth. They are the following. First, if the tooth is a cause of sepsis, chronic intoxication and infection. In case of generalization of acute process and development, for example, acute osteomyelitis or phlegmon. If there are less than 2 years before the physiological exfoliation of the tooth. If you see signs of pathological or physiological root resorption more than one set of the root length. If you see signs of internal root resorption on radiographs. In case or when pathological process spread to the gem of permanent tooth and you see violation of the integrity or thinning of lamina dura surrounding the gem of permanent tooth. The loss of functional value of tooth, like here, for example, excessive mobility, considerable breakdown of crown. The loss of the bone support as a result of severe destruction of a bone because inflammation in the bone. Next indication, perforation of the bottom of pulp chamber. It's visible on this slide, in this picture. Development of chronic periostitis, osteomyelitis, or odontogenic or follicular cyst. Absolute indications for extraction of primary tooth. Unsuccessful conservative treatment. If you try to treat this tooth, but it's led to inflammation. Severe general disease, for example, congenital heart disease, leukemia, or maybe immune system deficiency, immunosuppressive therapy. Why? Because, as you remember, primary tooth with apical periodontitis is a source of additional infection for the organism, and inadequate behavior of a patient and the lack of opportunities for the treatment with general anesthesia. For example, here you see indication for the extraction of primary tooth. Here you see signs of internal resorption, and here you see the big area of destruction of a bone, and at the same time you may see violation of integrity of the lamina dura near the gem of permanent tooth. Lamina dura almost absent. So, conservative treatment. Please remember that aim of conservative treatment with primary teeth is, if possible, to keep the teeth in function until physiological exfoliation, or at least for as long as they are important for occlusal development. But if you choose conservative treatment, please remember that underlying permanent tooth gem must not be at risk of any developmental disturbance or injury as a consequence of pulpal or periradicular involvement of primary tooth or the treatment performed. The task of conservative treatment of apical periodontitis of primary teeth. Stopping the clinical and pathological evidence of inflammation, elimination or stabilization the inflammatory, destructive, and resorptive evidence of inflammation, prevention the damage or loss of the development permanent tooth gem, restoration, we should restore the function and anatomy of the tooth. We should be ensure the adequate root formation or its physiological resorption in timely manner when they will be exfoliated naturally. The name for conservative treatment, we use so-called non-vital pulp therapy technique, or pulpectomy. As you remember, the pulpectomy, it means complete removal of the all pulpal necrotic tissue from the tooth. Pulpectomy includes the following steps. Creation of access to the root canal system of primary tooth, cleaning them as best as possible, using appropriate material to obturate the root canals, restoration of tooth crown, and follow-up. Now I want to stop in detail on all stages of pulpectomy. So first of all, of course, pain control, rubber dam isolation. Next, complete removal of the caries, opening of the pulp chamber, deroofing and opening the pulp chamber, and identification of root canal system. Doctor should be good in anatomy of primary teeth. On X-ray, you should measure working canal length. Canal length is usually established by measurement of the diagnostic radiograph, and working length of an instrument must be taken for 2-3 millimeters less radiographic apex. On this slide, you may see average length of the roots and crowns of primary teeth, and you may see that the working length for primary teeth less approximately 2 times than working length for permanent teeth. During endodontic treatment, you should remember endodontic treatment of primary teeth. You should remember that we use manual endodontic instrument of a large size, more often car files and edge files. Please prepare the canals no more than size 30. Gaze Glidden drills are not used in primary teeth for instrumentation or canal shaping because of the danger of perforation of the wall of the roots. Technique crown down should be given preference. That we should create apical stop at the level of the working length. Please remember about careful debridement of canals due to infected low mineralized layer predentin on the canal's wall. Please remember that over-instrumentation of a primary tooth root canal has the potential to the damage of underlying permanent tooth. Because many of pulpal ramification cannot be reached mechanically, copious irrigation during cleaning and shaping of canals must be maintained. That's why usually we remember about that we should use chemical means more than mechanical means. Antiseptic used for disinfection of root canals. 3% solution of hydrogen peroxide can be used, 0.5 till 3% solution of sodium hypochlorite, like Parcan, Belades commercial forms, solution of chlorhexidine till 2%, or maybe some commercial forms, can be used potassium iodine and normal saline. For irrigation of root canal, we may use special irrigating system or conventional syringe, but with special needles. In some cases, clinical cases, when you see purulent process, for example, pus in canal, or you are not sure in a good disinfection of root canal system during irrigation with antiseptic, you may leave for good disinfection in canal system some medication containing, for example, corticosteroid or antibiotics. Example of paste containing antibiotics and corticosteroid you may see on this slide, and the name of this one, leader mix. So swab of cotton wool, moisten it with leather mix or another disinfected solution, is sealed into the pulp chamber for 7-10 days. After instrumentation, you remember about rulers, how to do it with endodontic instrumentation. After disinfection, after irrigation, you should dry root canal system with paper point, and next stage, obturation of the root canal. Requirements for the root canal filling material for primary teeth. Ideal root canal filling material should resorb at a similar rate as a primary root, be harmless for the periapical tissue and the permanent tooth gem, should be resorbed readily if pressed beyond the apex, be antiseptic, has antiseptic effect, fill the root canal easily, should be good adhere to the walls of a root canal, be easily removed if necessary, of course be radio opaque, and not discolor the tooth. Nowadays, for obturation of root canal system of primary teeth I use paste based on pure zinc oxide eugenol, or some commercial form you may see on the slide, paste based on the Yoda form, like Tempa 4 and so on, based on phenol formalin, for example, like Rezapat and another one, and can be a paste as a combination of Yoda form, containing combination of Yoda form and calcium hydroxide. How to introduce material into the canal? methods for root canal filling. Of course, it can be manual method. This method we use more often in our practical work because small child mouth and child cannot keep open the mouth too long and very wide, and because some devices may be frightening for the child. That's why manual method is more popular. We use paper points or car file or gutta percha point or sterile syringe with disposable plastic needles, and we insert material paste for obturation. We insert into the canal, and after that we press and compact this paste in the canal with cotton pellet. But also can be used machine method, spiral root canal filler, or so-called lentula spiral. But please remember that lentula spiral is correspond to the canal of permanent tooth. That's why for child usually we cut it approximately 2 times with scissors. We do it more shorter. We use it according to technique, and when canal is completely filled, again the material is compressed with a cotton pellet. But according to some investigation, regardless of the method used to fill the canals, you should be careful about prevention of extraction of a material into the periapical area. We don't use for obturation of root canal system in primary teeth. We don't use gutta percha and silver pins. We don't use cement. We don't use material based on polymer resins. All this material we may use just in situation when gem of permanent tooth is absent. Next stage after obturation of root canal is a restoration of the crown. The tooth restored with restoration that seals the tooth from the micro leakage. Of course, it can be some stomatological material, for example, like composite. Or it's better if you have, if it's possible, to use crown. It can be a stainless steel crown or another type of crown, because crown provide very good isolation from the macro leakage. Here you may see steps of pulpectomy procedure in tooth. For example, opening the pulp chamber, removal of caries, opening the pulp chamber, access to the root canal system, instrumentation shaping of the root canal system, and irrigation, drying of root canal, obturation, and restoration with steel crown. Follow up. We should call the patient for follow up after 3, 6, and 12 months. And we should assess clinical situation near the tooth and ask about any complaints. So clinical size can be taken as an indication of success the following: absent of complaints, relief of acute symptoms, and tooth free from pain, mobility, or any symptoms of fistula or sinus on gingiva. Radiographic evaluation of primary tooth pulpectomy should be occur at least annually, 1 time a year. And radiographic science as an indication of success, improvement or no further deterioration of bone condition in the furcation or periapical area. Here you may see example, mandibular first primary molar with zinc oxide eugenol pulpectomy. And you may see in area of furcation there is small radiolucency, and the same tooth, primary first molar, 1 year after the treatment, showing bone absent of bone destruction, yes, bone healing, and no radiolucency in furcation area. Usually, treatment of apical periodontitis in primary tooth performed in one appointment, in one visit. Indication for one appointment technique are periapical abscess with sinus if root canals with good possibility to pass, or chronic apical periodontitis if root canals are well acceptable for instrumentation. But in some cases, we need more patient visit, more appointment. For example, if you detect inside the canal granulating tissue. Granulating tissue is, as I told before, may ingrow from the periapical area into the canal. This tissue is with a very heavy bleeding and painful in the process of instrumentation. That's why pulpectomy procedure in clinical case like this may require 2 or even 3 visits, because we should remove granulating tissue from the canals. Granulating tissue a little bit painful. That's why for analgesia of granulating tissue, we may use some solution. We take moistened cotton pellet, put it into the pulp chamber or insert into the canal, and wait till 5 minutes. On the slide, you may see example of solution for analgesia. Next step, removal of granulation tissue. It can be mechanical way, using excavator, using pulp extractor, or H-file, or more common procedure, removal of granulating tissue with some chemical drugs. We use so-called cauterizing substances. These substances burn out the granulating tissue. We may use pure liquid phenol, pharmacrisol. You remember about pharmacrisol, we use this solution in procedure of vital pulpotomy. It can be phenol-formalin mixture in differentiation 1:1 or 2:1, monochlorphenol solution, or some commercial liquid on the base of creosophene. A pellet moistened with cauterizing substances with excess moisture blotted should be placed into the pulp chamber for mummification or, as I told, burning out of tissue. The chamber should be sealed with a temporary filling material for 1-3 days. And at the second appointment, 1-3 days later, the tooth should be isolated, yes, temporary filling removed, And if the tooth asymptomatic during the interval and there are no signs of inflammation, and if granulating tissue is almost absent in the canal, in this case you may continue instrumentation, shaping of the canal, irrigation in usual manner as we discussed before. Emergency aid. Emergency aid. If the tooth has painful necrosis with purulence in the canals, or maybe some signs of involvement in inflammatory process surrounding tissue, like soft tissue, periosteum, and lymph nodes, completing the pulpectomy procedure over 2 or 3 visits should improve the likelihood of success. Stages of emergency care in acute and exacerbated chronic apical periodontitis depend on the choice of the most effective way for the exudate evacuation, because way for exudate evacuations can be through the root canal, through the gingival sulcus, and through the periosteum. If you choose the way of exudate evacuation through the root canal, after the diagnosis, decision of conservative treatment, pain control, of course, tooth should be opened for drainage with the following chemical mechanical debridement of the root canal. Doctor prescribes, so you should open the tooth for drainage. Doctor prescribed the mouth rinse for 1-2 days. Mouth rinse prescribed should be hypertonic. Additionally, we prescribe anti-inflammatory therapy, usually non-steroid anti-inflammatories or antibiotics, after 1-2 days, and relief of the inflammatory symptoms, we may continue endodontic treatment on the conventional scheme. But if you choose for way for exudate evacuation through periodontal ligament or bone periosteum, after pain control, we perform chemomechanical debridement of the root canal as described earlier before. I mean mechanical instrumentation and shaping of the root canal system, irrigation of the root canal system, and after that we fill root canals temporarily with paste based on calcium hydroxide or calcium oxide for 1-2 weeks. Also, doctor prescribe anti-inflammatory home therapy, non-steroid drugs or antibiotics. Endodontic treatment on the conventional scheme should be performed after relief of the inflammatory symptoms. After 1-2 weeks, we remove the temporary filling, we remove the temporary calcium-containing material from the canal and continue the treatment as described before. Which paste for temporary filling, root canal filling, can be used? Paste on the base of calcium hydroxide. Paste can, like calcium hydroxide powder mixed with saline or sterile water. This paste is prepared extempore, or can be used some commercial forms. You may see their names on the slide. And as you remember, in patients with acute apical periodontitis or exacerbated chronic periodontitis, emergency aid include prescription of antibiotics. Which antibiotic is better for this clinical situation? Penicillin or amoxicillin is the drug of choice. Metronidazole can be prescribed, and in some countries is the said alternative antibiotics in children, erythromycin, or in some country, clindamycin. For example, in situation when patient has an allergy to the penicillin. About dosage and course of antibiotics, you should use countries' guidelines for prescription of antibiotics for each country.